Good morning.
Morning.
We are going to do our webinar this morning on our survey that we had. And you're going to see me disappear for a second because I don't have it in my... I got it. Okay. All right, so on November 28th, the Commission walked in for an interim survey. We were randomly picked, and they were here to look at Medicaid survey items only. And before I finish that paragraph, I just want to go over a couple of things. Please silence and put away all your cell phones. Please don't document and do other work while you're listening, because I really need you to listen to this information. There will be a word for the day, and somewhere in the, I will say it. And if you'll please text me or email me or message me the word at the end of the webinar. Those that are live today do the same thing, and those that are going to listen in a later on, before next Thursday. If you have any questions, just save those to the end, and I'll have a question time then. And again, please just listen to everything that's going on, because it's really, really important that we get this straight. Okay, so again, we were randomly picked for Medicare to come out. They didn't do a whole survey, even though they were here 3 days. The surveyor made 10 home visits, and all disciplines, and she reviewed the patients she saw, and 2 additional ones. We also reviewed the personnel files of all the employees she saw on the home visits. Okay, I can hear somebody, and I'm not sure who I can hear, because I know it's not me. I don't know if somebody needs to mute or what they need to do. Okay, so overall, she was pleased with the care that was given to the clients on the home visits. Documentation continues to be our downfall. My hair's sticking up, so I'm trying to fix it. Sorry. We give great care, but if it's not documented or not accurate, it doesn't give us a gold star. It only creates more work. Because now we have to create a plan of how we're going to fix issues, and we have to show in the next few months improvement. And we have to send that to the Joint Commission. Okay, so areas of improvement. All communication about the patient, whether you send or receive it, should be documented in the chart. That's calls, verbal, text, emails, messaging. So if you come into the office and you see somebody in the hallway and you tell them something about a patient, then that should be documented. I'm also asking the office that if you call in and tell us something. So let's say you call in and say Mrs. Jones is in the hospital. I would expect you to document that, but what I would do also is I would document it. If it's documented twice, 3 times, that's great. I would rather that be done than not at all. Okay, so the plan of care should be a collaboration with the physician, the patient, and the clinician. The physician must be notified about the admission and the initial visit. So, except for Dr. Miller. Dr. Miller does not like to be called to say, we've opened your patient. And that's in his protocol. But you must document. Okay, I'm really hearing a lot of stuff, and I'm not sure what I'm hearing. So somebody needs to mute. Yeah. All right, hold on, I'm trying to get Brent because I'm hearing a lot of background noise and I'm not sure why I am. Okay, so you must document who you spoke to, and you must document reviewed plan of care, received verbal approval of plan of care, okay? Especially the therapist. Okay? I'm hearing a lot of, I don't know what I'm hearing, like water running and all kinds of things.
Okay.
So somebody's not muted.
You can always mute them.
Okay, I didn't know that. Hear it?
Mm-hmm.
Okay, so specialty therapy, and that's what she looked for. So everybody should call the doctor, PT, OT, ST, nursing, when you're admitting a patient. And you need to, who you talk to at the doctor's office, even if it's the receptionist out front, you get her name, which doctor you call, because the patient might have multiple doctors. And then you have to put reviewed plan of care, received verbal approval of plan of care. That statement has to be there. That's what she was looking for. Okay, and if that is not there, then that's against us. Okay? All right. Somebody's like fixing their breakfast. Okay. Okay. So the problem is what she found. The physician was called after the admission, but there was no documentation of who they spoke to. The physician wasn't called after the admissions and evals. That means you didn't even care to call the doctor to let him know, hey, you're supposed to be part of this plan of care. We don't care, so we're just not going to call you. The physician was called after the admissions and the evals, but nothing documented about what was discussed. So again, if nursing opens the case, they call the doctor and say, we're opening and this is what's going on. Or we're opening, we just made an evaluation. If therapy goes out for the evaluation after nursing, then they call also. Okay? There's not a, we can't do it, we have to do it. Okay. Communication is very important with the patient or caregiver. We will learn in the next few weeks with the new conditions of participation for Medicare that require the patient as well as the caregiver to be part of the care planning. And they must be aware and agree to any changes. A lot of times we have the patient and the daughter works, and we discharge the patient who has some memory issues maybe, and then the daughter calls and says, well, I didn't know you were discharging my mom. That's really a part of that whole thing, is that caregiver should be part of that plan also. The information is communicated verbally and documented in writing by using standard forms, which is a discharge notice, that kind of thing, and in the patient folder. All visits must be documented in the patient folder. And the problem she found was that nobody was documenting in the patient folder. Some patients, we go out and we can't even find the folders. Okay, so communication with the home health aide can be verbal. You have to document that. So if you saw the home health aide and you went over something with her, and in writing using the aide care plan. The aide care plan tells the aide what they're allowed to do or not to do with the patient. The care plans have to be specific. They cannot decide what they're going to do. It has to be on the care plan what and how often, or they can't do it. So please fill out the care plans accurately and completely and individualize each care plan for the patient. Talk to the aide and review the care plan when making a supervisory visit, because sometimes things change. The patient may be a bed bath when they first start out, and then when they are get therapy in there, then they progress to a shower. And so once they do that, then the care plan has to change. So what she found was that the care plans weren't specific. It didn't indicate what type of bath to give. Again, that circle of complete or partial, or shower or tub. And she didn't indicate which day to perform the laundry. Now, I know that is really specific, and we have never done that, but that's something she said it needs to be done. And then if the aide can't do it on that certain day, then she's supposed to call in. Okay, so documentation is material that provides official information or evidence or that serves as a record. Documentation serves as interdisciplinary communication, compliance with standards and accrediting organizations, compliance for reimbursement standards, and documentation of care. So what should you document on? You should document on what you assess, what you observe, what you do, which is your interventions, how it's done, what it looks like. So if you're doing wound care, if you're looking at an incision, if you've got a Plerex drain, wound vac, whatever it is, what you educate, what you instruct, what the patient's response is, what they say or do, any problems or issues, who you called, the actions, the resolution, and what the plan is. So what are we still planning on doing with this patient? So examples of the problems found on the survey. A PICC line was removed. We had an order for it, thank goodness, but all it said was PICC removed. It didn't say what the site looked like. It didn't say what the tip of the catheter looked like. When I emailed y'all for nurses, I included the PICC policy to make sure that you knew what needed to be documented on. If you're drawing blood, you need to document where you drew the blood. If you stuck them, how many times you stuck them. I mean, all those are details. We also had a patient on oxygen, and there was no risk assessment or O2 safety check done on admission or on follow-up notes. So when a patient is admitted and they're on oxygen, first of all, it needs to be on the medication profile because it's considered a medicine. And then second of all, you need to do a risk assessment. It's a drop-down box on the evaluation, and then you need to follow up every time. Does the patient have portable tanks? Are they stored properly? Do they have a smoke detector in the house? Do they, have you gone over the, not to smoke a cigarette while the oxygen is in your nose? All that stuff, while you're cooking on a gas burner. I mean, those are things we've all seen, but that wasn't done. So that's, thank goodness that was only one chart that she found. But I'm sure if we looked at everybody on oxygen, it would be the same. So again, you need to document, you need to assess, and you need to instruct. The one thing, let's go back to the home health aide care plan. One thing that was mentioned yesterday when we did this was that if a therapist is teaching an aide anything about range of motion exercises, that has to be on the care plan. You have to document in your note that you instructed the aide in the range of motion and how to work with the patient, and then that has to be specific on the care plan. Our aides also do not do vital signs. But if there's something that the patient has to take their blood pressure and they have a machine and they need help with that while the aide is there, then that has to be documented that you showed the aide what to do, and again, then it has to be on the care plan. Yes, that would include weight. So if they're supposed to help with weight, then yes, that needs to be added to the care plan. And just remember, so if it's our aide, then we can adjust the care plan. We just have to be careful about other aides that are out there from other companies because we don't have anything to do with their care plan.
What about these, like these places now that they have, where they have multiple people in the houses, and it's a homeowner that's
Like a group home?
Yeah, there's group homes.
Yeah, if it's like staff of a group home or assisted living or something like that, yeah, as long as you document that you went over that with somebody, then that's fine.
Right.
Okay. All right. All right. Medication reconciliation and review. Yesterday before I said this, I took a deep breath, and I'll take another one today, okay? I cannot say how important this is. This is not something that she just all of a sudden gave us new information on. This is something that we already knew about, that we've already had training on multiple times, and we still didn't do it, okay? So medication reconciliation is the process of creating the most accurate list possible of all medications a patient is taking, including the drug name, dosage, frequency, and route, and comparing that list against the physician's admission, transfer, or discharge orders with the goal of providing correct medications. So basically, it is comparing what they came home from the hospital with. If they went to the doctor's office and got a new med list, it is making sure that the patient has the correct medications and is taking the correct medications. The drug regimen review is a review of all medications the patient is currently using in order to identify any potential adverse effects, drug reactions, including ineffective drug therapy, significant side effects, significant drug interactions, duplicate drug therapy, and noncompliance with drug therapy. So that's basically looking at the med list, going over it with the patient, and making sure, again, that they're taking the correct medicines. And this is big because most of the hospitalizations occur because the patient is not taking the correct medication or doing it wrong. Okay, so here's what she found. Not checking the medication bottles. I still don't even know what to say about that. Not checking the bottles is something that we have drilled over and over again, and I can't believe we weren't doing it. Patient had a bottle of Lantus that had expired. It was over 30 days old. It was sitting out on the table, not even sure if it had been refrigerated. The medication bottles weren't stored properly. She found the medications mixed in with other family members' medicines in a basket. And then we had a patient who said, had a bottle of Tylenol, and she said out loud in front of the surveyor, "Oh, that's not Tylenol, I'm keeping Advil in there." So here is what we need to do. We are in the patient's home, and I know that they can store whatever they want to, and they can keep whatever they want to. Everybody doesn't want to give up their expensive medicine bottle because the doctor may put them back on that medicine, and then they're going to have to buy it again. But if they're not taking something, one thing that Gretchen does is that she takes those extra medicines, puts them in a bag, ties them up, and puts a note on there, "Please don't take these," okay? And then she sets them aside. If the patient has the medicines mixed in with the husband's medicines or the sister, the daughter, whatever, then ask them to remove them, get a different basket or a different place for them. And then if the patient refuses, then we have to document that. You know, we've asked them to do something, like we asked them to do something else. You know, find out why they don't want to do that. Is it inconvenient? They can't read, you know, what's the reason? And try to help resolve that for them to say that it is safer if you keep things separately. You know, we have patients that say they're taking their husband's Cinepril, they're taking the, you know, again, we have to document what we've instructed, but if they continue to do the wrong thing, we definitely have to tell the doctor, but we have to find out why they're doing that. You know, that just doesn't make sense. Can they not afford the medicine? What's going on? So all disciplines have to check all bottles of medication and the expiration date every visit. That's mandatory. All disciplines, and this is from the auditor, all disciplines need to open the bottles of medication and let the patient tell you what is in them every visit. We don't have to recognize the medicines because, unless you're really, really great, I don't think we'd all be able to do that. But we need to open the bottle, let the patient open the bottle, you know. See if the patient can read the label, you know. Can they say, "Oh, yeah, that's this, that's that," but make them read the label. Make sure they know when they're supposed to take it. A lot of people have been on medicine for a long time and they still take it incorrectly. The other problem she found was we're not comparing the medication profile with the medication bottles with the medication list in the patient folder. Again, I have the 3 lovely pictures there. 3 things you check: medication bottles, the medication profile in your iPad, and the patient folder. All three have to match. All disciplines have to compare all of those things every visit. So if the patient's seen 3 times in one day, it's going to get done 3 times in one day. What we found, or what she found, we had duplicate orders. Patient was on Coumadin. Patient was changed to 5 milligrams. Nobody discontinued the 2.5 that they were taking before. Again, if those 3 things had been checked, that wouldn't have been an issue. Patient was on 2 doses of insulin. 2 doses of insulin were on the medication profile. There was a PRN medication on the profile, but the patient wasn't taking it and never had. So if the patient is, when you review, again, if that review had been done, and I think this was a medication for nausea, and the patient says, oh, I don't take that. I mean, actually the nausea medication had been ordered 6 months previously. She had just never taken it, so just take it off. So again, the resolve. All disciplines check the medication profile and update it every visit. So the problems that you saw about the insulin, one doctor had told the patient to take 55 units, another doctor had told her to take 65 units. And that was actually documented in the chart. The doctor wasn't called, and the problem wasn't resolved. Nobody called and said, what is she supposed to be taking? So that just doesn't make sense to me. If there's a discrepancy, you need to take care of it. Okay, care plans. The patient has to have a care plan with goals and interventions for each discipline that are specific to the patient. If you are seeing the patient only one time, it's just an evaluation, you don't need to do goals and interventions because you're just doing it. You've done it, and there's nothing in the future that you're going to do. You could do one, but it has to be resolved, okay? On ROC orders, new or updated goals must be on the order to the physician, meaning when we admit a patient, our goals and interventions from our care plan go on that plan of care and are sent to the physician so the doctor knows this is what we're working on the patient with and this is what we anticipate is going to happen, what our outcome is going to be, and we think it's going to take 4 weeks. On a resumption of care, you're doing verbal orders, so you're just sending a verbal order of frequency 2 times a week for 4 weeks for whatever you're doing. You're updating or changing your goals and interventions, they need to be on your order also. Okay? Same thing, even if you're doing a verbal order for, let's say the patient develops, I guess, a skin tear, okay? And you go out and you see the skin tear, you get an order for whatever we're doing for that skin tear, and you add it to the care plan, then that should be on your order. Okay, so here's what she found. She found an intervention and a goal that said uncontrolled symptoms or education reinforcement. It did not say, wasn't specific to a diagnosis that the patient had, education reinforcement of what, it was just very, very vague, okay? She also saw that skilled nursing was seeing the patient week 1, but there was no care plan, no interventions, or no goals. Orders. Orders not followed and PRN orders not specific. So what she found was we had a patient we were doing wound care on. We had MediHoney documented, TheraHoney documented, and TheraHoney AG documented. All documented, but the TheraHoney was what was on the order. Normal saline was on the order, but it was documented that we cleaned with soap and water. The order said ABD and cling, but it was documented that gauze was put on before the ABD. So, resolve. Only do what the order says. Only document what is on the order. And call the physician and get new orders before doing something different than what is ordered. Again, that is not new. None of this information is new, guys, except maybe opening the bottles and seeing what's in the bottle. Please, please, please make sure that when you document, that you are not cutting and pasting, that you are looking at the order when you're documenting, Document while you're in the home, that would be great, or document immediately when you leave, because when you're documenting 2 or 3 days later, you're saying, oh yeah, this is what I did, but are you really remembering, and are you looking at the order? Because you have to do and you have to document what is on that order. And if the patient doesn't have, I don't know, if the patient doesn't have their stand salts, okay, well then you're going to have to call the doctor and find out what do I do until that gets here. You can't just do something because they don't have something. Okay, we had an order for OT that was never scheduled. A new order was put in with no communication why. Please, please, please make sure you're alerting scheduling when you're changing anything or adding any new disciplines so that it makes sure it can be scheduled. Please call a physician and document if your visits are missed. And please, I'm asking you to put the reason for discharge when you're doing a discharge for a discipline. So let's say you go out, you do an evaluation, the patient's supposed to get OT, and they say, I don't need OT. So when you call the doctor, you're going to let them know that, but you're also going to put a discharge order in for that OT. But please put the reason, patient refused, or no OT needed. And that just makes sense because that's communication with the doctor. Okay, PRN orders, not specific. PRN orders must be specific to the patient and their diagnosis. So PRN for equipment, such as a Foley, feeding tube, a Pleurax drain, wound vac. If they have CHF, it can be PRN for weight gain or increased shortness of breath. But it can't just be 6 PRN for patient problems, deterioration, condition. It just can't be. That's just way too general. It has to be very specific, and I probably would not put in more than 2. The 5 or 6, it's really just, that's really more for convenience. Hey, if something happens, we can go out and we don't have to write another order. We can't do that. Okay, miscellaneous stuff, abbreviations. If you're not sure if it is an acceptable abbreviation, please don't use it. And what I said yesterday was I would just be happy if you could just phase out the abbreviations. Because what we're doing is we're using abbreviations that we don't even know here in the office what they are. We're using PT for patient and PT for therapy. So spell patient out and make sure that PT is capital. We have abbreviations that we can't use for Joint Commission. It's a list of probably 10, 15. And then we have a list in our book of pages and pages of ones that we can use. Again, what I'm asking is just phase out the abbreviations. When we're documenting on the patient profile for medications, it should be, we should not be using abbreviations anyway because the patient's not going to be able to understand that. And then also in a note, if we don't know what it is and we have to call you and say, what is that abbreviation? Then again, when in doubt, please just don't use it. Identifiers. You always use 2 identifiers to identify the patient, especially when you're doing an invasive procedure like drawing blood, doing a Foley, anything like that. If you've seen the patient before on the current admission, then facial recognition can be one of the identifiers. But what she said, we had a patient that we had before, previously, months before, okay? And we went out for an evaluation. We called the patient's name, which is an identifier, but we didn't use another one. You know, even though we had seen that patient in the last 6 months, she said that that's not okay. You still have to use another identifier, their birth date, their social security number, whatever you need to use. But if we just saw the patient, if we did the evaluation on Monday and I'm going back out today, then facial recognition is fine. But she looked for that when she went out on the visit. So you have to make sure you have to do that all the time so that the patient's not saying, oh, you've never done that before, you've never asked me that before, why not? Okay, so the problems found at survey. Abbreviations were used that were not accepted standard abbreviations, and the clinicians did not use 2 identifiers. Okay, so questions. It looks like we have, I see Amanda Wade on, and then there's another person on.
Ashley, probably. She's listening while driving. She said she can't
Okay.
identify herself.
Okay, that's fine. Okay. All right. All right, so Amanda, you may be the only one that can ask any questions. Do you have any questions?
Nope.
Okay, well, the word for the day that you're going to need to text me or send me is confabulate.
I think you made that word up.
I didn't make it up.
On there too. She just texted.
And
All right, well, hold on. They're blowing the leaves out front, and I can't even hear y'all. Okay, so let me just write down Wade and Jessica
And Ashley.
and Ashley. Okay. All right, Jessica and Ashley, you can't ask questions, but
Melanie,
but if,
Melanie,
yeah.
hi, it's Amy Dodd. Can
Hey,
you
Amy.
say that word? Can you say that word again? Because I didn't catch it. Like, I think the background noise.
It's confabulate. CONFABULATE.
Gotcha. Thank
Okay.
you.
So any questions about anything? No?
So,
Jessica wants the definition.
And then I'll give you, when you text it to me, I'll give you the definition.
She just texted me, what, question mark?
Okay. All right, well then that's it. And again, these are not new things. You have a question? No. And these are not new things, but these are things that, again, when they come back, we cannot get caught on the same thing. Our plan is to, next week, start on the new conditions of participation, which start January 13th. Again, some new things. Really, it's all about documentation, which that's why we've got to get a little bit better with that. And then we're planning on going out monthly with every clinician for the next year until they come back again, because more than likely they'll be back in January. So if you have questions, if you are in doubt about what to document, or if you have a question about anything, please call us here in the office, because that's what we're here for. Okay? All right. Thank y'all very much. Bye. Oh, I don't know how to get out of here, but right. Bring us there?
Yes.
All right. Thanks for coming in. I appreciate it. So it was Amanda,
I couldn't
Jessica.
figure out the computer thing, so.
That's fine. So, Amanda, Jessica, Ashley, and
And Amy Dog.
Amy Dot, and Joe.
Any of your people follow up?
Confabulate. It means to converse. Yeah, I don't know how, what I'm doing. It's still recording. Do I talk about people now? Well, we don't know if I want to.